Infections in the neonate can fool you because neonates present with lots of non-specific signs and symptoms. The younger the child, the more vague the signs and symptoms, and so the more aggressive we have to be. It's very important to be aggressive with these babies because they can die very quickly. Signs and symptoms can be something as easy as hypothermia or temperature instability. They don't necessarily have fever. So look for hypothermia, temperature instability, poor feeding. Sometimes they can be shocky with poor perfusion. They can even be cyanotic. They can even present with respiratory distress. The etiology of the sepsis in the newborn, you have to know your common germs because that will determine what your treatment will be. So some of this information is actually valuable for step 3 too, also. The most common causes of sepsis/meningitis in the neonate, number 1, group B strep. Also think of E. coli and listeria. And the 4th one that you need to worry about is the virus herpes simplex. So those are the big ones that you need to worry about in the first couple of months of life. As the baby gets older, we'll discuss other etiologic agents. Look for a baby that was born prematurely when you're reading the test question. Look for a mom that maybe had fever. The preterm labor may have been caused by some kind of maternal infection. Look for maternal fever. Look for prolonged rupture of membranes. All of these things predispose the baby to sepsis. And again, the signs and symptoms can be very nonspecific. Temperature instability, they can be poor feeding. Labs, you have to get everything. You're going to get a chest x-ray because you're going to make sure the baby doesn't have a pneumonia. You're going to get a CBC, a low or high white count is very indicative of sepsis. You're going to get electrolytes. You're going to get cultures. You're going to get cultures of whatever you can culture. So for example, you're going to get CSF cultures if possible. You're going to get blood cultures, urine cultures, and any suspicious lesions should also be cultured. And the treatment will depend, that's why you need to know those organisms. Antibiotic treatment, you're going to use either ampicillin and an aminoglycoside, or you're going to use ampicillin and a third-generation cephalosporin, such as cefotaxime. Cefotaxime is preferred because it doesn't cause biliary problems that ceftriaxone would. So you try to stay away from ceftriaxone under 2 months of age. Once you get your cultures back, you can then tailor your treatment. Ampicillin is good because it can kill group B strep. When it's given with cefotaxime, it covers listeria, which the third-generation cephalosporin don't cover them. Also remember acyclovir if you're suspicious for herpes simplex virus. The congenital infections, or the transplacental infections, we also have a mnemonic for them, or an acronym called TORCH or TORCHES, and it stands for toxoplasmosis, the T. The O can also stand for other, which would mean syphilis, but you can have them there: toxoplasmosis, rubella, cytomegalovirus, herpes, and syphilis. Most of these are acquired in the 1st or 2nd trimester. Remember that. Toxoplasmosis, you can get it from undercooked meat. So remember the famous steak tartare. That can carry the toxoplasma in it. It can also be transmitted in cat feces. That's why any pregnant female should not be handling the kitty litter because she can acquire it that way too. It's notorious for intracranial calcifications, and we're going to mention that, and then we're going to talk about cytomegalovirus that also has calcifications, and we're going to differentiate them in a second. You can diagnose this with titers. The best first test for any of these is to get TORCH titers or specific titers for whatever disease you want, but that's the best first test. You can treat this disease. If the mom has the disease, you can treat her with spiromycin. Once the baby is born, the baby will get pyrimethamine. You can also treat with sulfonamide. And for the first 6 months, if the baby's on sulfonamide, you need to treat the baby with leucovorin because of bone marrow suppression caused by the sulfa drug. So this is to show you mom playing with the kitty, handling the kitty litter, undercooked meat. These are intracranial calcifications. They're scattered about everywhere. So on this MRI, you see them here. They seem to be scattered everywhere, in no particular order. You can get, we'll differentiate them from the cytomegalovirus in a second. And a lot of these diseases can cause retinitis. So all these babies require ophthalmologic evaluation. The torch infections are difficult to distinguish one from the other, and so that's why we're telling you one little thing about each one. Remember, you need to get titers to help differentiate one from the other for the most part. Congenital rubella. Again, a first trimester disease. 80% will occur in the first trimester. They can cause intrauterine growth retardation. We talked about SGA babies a little while ago. This is another cause. Usually this will cause symmetric IUGR, so that tells you that brain growth is being affected. These babies can have cataracts, so that's another cause of congenital cataracts. We mentioned galactosemia, we mentioned torch, particularly rubella. These babies can have heart defects, particularly ASDs, VSDs, and patent ductus. A very characteristic term, when you're reading the test question, you're looking for it, it's called blueberry muffin lesions. These are areas of erythropoiesis that are seen on the babies. They're like little purpuric lesions, and since the baby is jaundiced, that's another thing that can happen with them, they look like little blueberries. So look for what's known as the blueberry muffin lesions. They're sometimes described in other diseases, but certainly put this at the top of your list. If they mention that, think of congenital rubella. You get titers with IgM, and the best thing to do for this disease, you can't treat them once they're born. The best thing to do is to prevent them from getting the disease by immunizing the population so they can't transmit it to the moms. And this is a baby with the characteristic blueberry muffin lesions. All those little spots that you see on the baby are little areas that they call the blueberry muffin, simply because of the color with a background of jaundice. That's what you describe. This is a baby with cataracts. Again, we talked about galactosemia, but also think of congenital rubella. And so you see these areas here with these defects, these just opacities in the baby, in the eye, the lens. Cytomegalovirus is one of the other torch infections. Most people who get cytomegalovirus don't have a lot of symptoms, and most of us, if we were tested, might have CMV positive. The problem occurs when you're pregnant and you get cytomegalovirus, and it causes a lot of damage to the developing fetus. Among these problems, you can have a retinitis, you can have intrauterine growth retardation, you can have seizures, mental retardation, and one of the things to look for is periventricular calcifications. So as opposed to the toxo that we talked about, calcifications scattered about, look for, in this particular case, periventricular calcifications. As you see on this CT scan, there's the ventricles in black, and all this white stuff, those are all calcifications, okay? Looks like the baby has a little bit of hydrocephalus too. Those are kind of generous ventricles, and you can see over here some atrophy. So this baby's going to have a lot of serious problems. You can diagnose this through titers, you can also culture, and you can, probably the better one would be to do polymerase chain reaction and PCR, or PCR for CMV. Once the baby is born, these are all sequelae of the infection. So this baby's not really secreting cytomegalovirus. This baby is not contagious to anybody. The fetus has acquired this from the mom. This is the response to that infection, but the baby's not actively going to cause infection to anybody else. So there's no treatment for this. This is herpes simplex virus. It can present one of three ways, what we call local, which is just skin, eyes, and mouth, or SEM. It can be disseminated, and these patients present with shock and sepsis, or you can have central nervous system with seizures. The treatment here is going to be acyclovir. Remember, the best way is to prevent the baby from getting HSV disease. If the mom has an active lesion, then it is best to deliver the baby by C-section. However, that is not a 100% guarantee that the baby won't get HSV, but it's better than being born through an infected birth canal. That's probably an OB question. We'll give you that one for free on Pediatrics too. This is a baby with herpes simplex also. You can see all these skin lesions. Actually, the skin manifestations, if you had to pick, the baby with local disease has the best outcome and prognosis. These babies have 100% survival and very little problems with seizures or mental retardation or developmental delays or anything like that. It's the ones that have disseminated disease that can be fatal. CNS can be fatal with severe neurologic sequelae if they do survive. Syphilis. Syphilis never goes away. It's always going to be there, and congenital syphilis is something that you might get tested on. It is going to be divided into early and late manifestations. The early manifestations of syphilis are those that are considered under 2 years of age. That means the baby may have fever, a recurrent or persistent fever. The baby may have anemia. The baby may have failure to thrive. These are non-specific things. You've got to put them all together. The baby may have a rash, and it's not the characteristic rash that you see with more advanced stages of syphilis. The baby can also have what's known as the characteristic snuffles. I'll show you a picture in a second. This is almost like a persistent runny nose in the baby, and that runny nose has spirochetes in it, so be careful when you touch that baby's runny nose. The baby may have hepatosplenomegaly, and they have periostitis. Periostitis is the only skeletal manifestation that you'll see in the early stage of syphilis in the newborn. The late stages of syphilis, after 2 years of age, are going to be mostly musculoskeletal manifestations, and they include the saber shin, the peg-like Hutchinson's teeth, the Clutton joints, which are these effusions, and the saddle nose, and the ragades. Ragades are basically these little clefts or grooves at the corners of the mouth. So here we have a baby with snuffles. And again, like I said, this baby, you better be wearing a glove when you touch that baby's runny nose, because that runny nose is chock full of spirochetes, and you can get an infection from that baby. If you put that under a dark field microscopy, you'd see spirochetes everywhere. This is the rash that you see from syphilis, kind of nonspecific it looks like here, and it can occur everywhere on the patient. This is the desquamating rash of syphilis, which can occur anywhere also, so it's not limited to just one area. Congenital syphilis, this is the saddle nose. These are the Clutton joints and the Hutchinson's teeth that you'll see. These are the late manifestations of congenital syphilis. Again, you're going to run VDRLs on these babies and RPR on the baby, and the treatment will be penicillin. Varicella, neonatal varicella and congenital varicella. So neonatal varicella is defined as delivery within 1 week before or after the maternal disease develops. That's called neonatal. Congenital varicella is going to be the mom has varicella during the pregnancy. Neonatal varicella is treated with varicella zoster immune globulin if she develops varicella 5 days before to 2 days after delivery. Otherwise, you don't treat the baby with VZIG. Okay? You can treat with acyclovir. Congenital varicella is going to be associated with much more limb hypoplasia and scarring. Also, congenital varicella is one of these type of torch infections. It can cause microcephaly, the chorioretinitis, similar findings with the other infections. We just have to get titers. And again, look for infection in the first and second trimesters for most of these torch infections.